Hello, my name is Linda Aduba. The theoretical foundation that fits into my clinical scholarly project is RM self-care deficit theory. Theory overview. My CSP is reducing hemoglobin A1C level among Hispanic adults with type 2 diabetes using a culturally tailored diabetic self-management education DSME program. Dorothy RM self-care theory was established in 1971. RM believes that in order to engage in self-care, individuals must have the ability to learn, to decide, and to manage oneself. Self-care deficit theory conceptual framework. The self-care model is one of the comprehensive self-care theories offering clinical guidance for planning and implementing self-care standards. The theory is based on the argument that after appropriate education, human beings are capable of attaining the competencies necessary for the initiation and sustenance of self-care. In other words, self-care is a set of voluntarily initiated and sustained activities aimed towards the maintenance of life and well-being. RM in her theory acknowledged that individuals have the ability for self-care, but when such ability is distorted due to knowledge deficit, nurses can help individuals to regain the ability by providing educational support, meaning that self-care derives from showing patients how to do certain things and sometimes doing those things for them until the point where they can develop the competency to do those things without further professional help. The self-care agency is the learned skill needed to perform the self-care activities, while the therapeutic self-care demand is the totality of the self-care measures needed to maintain one's life, health, and well-being. Theory and evidence base. A culturally tailored DSME is a proven approach to educating, engaging, and empowering diabetic individuals to self-manage their disease better, avoid complications, and reduce the associated costs while boosting outcomes. According to RM, there are situational disparities that affect self-care behaviors, and that includes ethnicity, culture, socioeconomic background, educational level, employment status, and lack of knowledge. Social factors such as education, poverty, and a language barrier play a significant role in Latino health. About 1 in 3 Latino adults fail to finish high school, 1 in 4 lives below the poverty level, and 1 in 3 do not speak English well. Hence, there is an urgent need for a culturally sensitive, literally tailored interventions in combating the diabetes burden in the Latino population. Implementation of the theory of self-care deficit. In applying RM self-care deficit theory in my CSP, the participants' diabetic self-care management knowledge and self-care needs were assessed using a pre- and post-diabetic self-care management questionnaire. The DSME plan was designed and developed to fit the participants' cultural and literacy needs. The DSME program will provide education on healthy diet choice and exercise among Latino adults with type 2 diabetes. The program is projected to last for 12 weeks, after which the patients will be allowed to continue the self-management on their own. The participant self-care education adherence will be reassessed using A1C level pre- and post-DSME intervention. Best practices. It is my hope that the findings of the CSP study will lower A1C levels, prevent diabetes complications such as kidney failure and cardiovascular diseases, and serve as a cost-effective means for reducing hospital admissions and readmissions. I also hope to see a decrease and improvement in the psychosocial and behavioral features of type 2 diabetes, hence enhancing self-empowerment for the participants. And most importantly, the stakeholders involved in the study, especially the clinic administrators, will adopt the life-saving, cost-effective, culturally tailored DSME measure in the management of diabetes among Hispanics with type 2 diabetes. Once again, my name is Linda. Thank you so much for listening to my presentation. Thank you. Bye-bye.